And the treatments these days, for the most part, are not doing anything, in my opinion, at least in the standard approach, to fix anything. They're really just basically covering up the symptoms. Your blood pressure is not high enough, so we'll give you this medication to cause your arteries to constrict, or the opposite, to dilate. Whatever the idea is, that's not treating the problem. That's treating, to me, symptoms.
Welcome to My Pod's podcast. I'm Dr. Joe Schneider, and after 35 years as a functional neurologist, a personal journey through stroke recovery, and helping thousands of patients, I'm here to share breakthrough solutions for POTS and neurological wellness. From getting out of bed in the morning to rebuilding your nervous system, this is your guide to understanding and overcoming neurological challenges. Let's begin this journey to recovery together.
Well, you can kind of just
from there introduce the fantastic Adam Klotzek, Dr. Adam Klotzek.
Oh, jeez. Right?
You've been a teacher
completely overrated.
For how many years?
I've been at this for what, 25 years?
25 years.
Take a little bit.
Yeah, exactly.
Yeah. You ever take a little bit in neurology?
Yeah. So when you have a lot of persistence and you do things at kind of like a high level in your investigation of different topics and subjects,
right.
You get learn a little bit about the nervous system.
Yeah, you do. Someone says, well, you must be real smart and stuff like that. And I never really considered myself as being super smart. I'm just persistent.
You're stubborn.
So I'm stubborn. I don't give up. Like if I have a question and I need to figure out an answer, I'll just keep dwelling at it.
Yeah, exactly.
Until I come up with an answer. But I've always taken neurology, from a chiropractic standpoint. I'm initially trained like you are, but both of us are initially trained as chiropractors. So I've always looked at neurology and, the functional neurology from that standpoint.
Yes.
Always like, okay, well, how does the adjustment affect things? How do people's postures influence these disorders? Because ultimately, I mean, in my practice, that's what I would treat. Those are the things that I would address, and then it morphed into more, the brain stuff, the vestibular system, the eye movements, and a whole host of other stuff as we learn more about the nervous system, over the past couple of decades. But I've always looked at it from the standpoint of just being, looking at the spine, looking at it from a chiropractic standpoint. So, yeah.
Exactly. Yeah. And actually, as the terrain changes, and chronic illness came in to play in the after the year 2000, we started seeing a lot of chronic illnesses, developmental disorders, and so forth. The thing about, when I was doing a lot of the work with Dr. Millow's brain balance centers, kids would come in with like many, many different complaints, their digestive tract was off usually. They were wet in their beds, even, into their teens. They would have different type of allergy symptoms, headache, pain, neck pain, low back pain, numbness and tingling in their extremities, primitive reflexes. It became a cornucopia of complaints, and then it was all of a sudden it was like, it's not just a headache, like,
right.
Yeah. So the patients bring the challenges, and
yes.
So one of the most searched things now on the internet is POTS and postural orthostatic. I used to call it tension syndrome, and now if I say that online, everybody's like, "It's not tension; it's tachycardia." And I'm like, okay. Well, heart rate.
Yes, I've been corrected.
Blood pressure, and even oxygen. I should call it postural orthostatic oxygen syndrome or something like that.
Right.
They all go together. But one of the fascinating things is heat intolerance.
Okay.
So I've gotten a lot of cases in which a person will say, "Hey, I can't get a shower. I pass out in the shower." Right. So they have to clean themselves, using a washcloth, like the old washcloth in the sink type of thing. When you're a kid, your mother put you in the sink and drowned you, dunk your head in, like, So people are going,
Especially when you were
that.
bad.
And so
Especially when
when
you were
people
bad.
tell me about it, I'd laugh a little bit. They're like, "What are you laughing at?" I'm like, "Oh, I'm not laughing at you. I'm laughing at memories." Um, so, when the challenge comes, as a functional neurologist, we got to say, okay, what are the controls that control your temperature? Okay.
Okay.
And most of the cases that come in have already been to cardiology. Had their heart tested either by a vital scan, tilt table test, or a EKG, or a stress test, and things like that. All the standard cardiovascular tests that are being done with patients.
Mm-hmm.
They're given the hydration and salt, right? Electrolytes and hydration. So mostly being electrolytes and hydration. And sometimes they just stop there. Then other times they give you beta blockers or midodrine to handle a regulation or a forcing of your heart rate so that you don't have fluctuations in it. But and I think I hope
Hope so too. For the sake of mankind.
mankind, that fluctuation is a part of reacting to your environment.
Right, right. You
Exactly.
know, you know, the first thing that just comes to mind in you just saying this about, POTS and stuff like that. To me, POTS is not a cause of something. It's really the reaction to something else. So POTS to me is really a symptom, and it's a symptom of a breakdown in that regulatory system you're talking about, the one that kind of regulates your blood pressure, regulates your heart rate, controls things when you stand up and sit down. So something's gone wrong with the circuitry there for whatever the reason might be. You might have, had a concussion and damaged that area, or, maybe you had a toxic reaction to a medication or a vaccine, or something's happened where those circuits have been damaged. It's the way I look at it. And the treatments these days, for the most part, are not doing anything, in my opinion, at least in the standard approach, to fix anything. They're really just basically covering up the symptoms. Like, okay, so your heart, is not beating regularly. All right, well, we'll give you this medication to calm down the heart cells or something. Or, or your blood pressure is not high enough, so we'll give you this medication to cause your arteries to constrict, or the opposite, to dilate. Whatever the idea is. That's not treating the problem. That's treating, to me, symptoms.
Oh,
You're just
exactly.
managing symptoms. Yeah,
Yeah, we're on the
and
same.
the problem is really the problem is really a central issue. It's an issue somewhere in the circuitry within your brain that should normally control your heart rate and heart pressure, or blood pressure, I'm sorry, when you go from sitting to standing. It just happens to be that that system that controls that is also linked to the regulation of temperature. So
Yes.
you're going to see a lot of these people with POTS also have heat intolerance, you know, and it's pretty simple. If you can't get your blood pressure to come up when you stand up, you're going to be more susceptible to having issues of passing out when you take a hot shower and you cause your arteries and stuff like that to dilate. As you warm up the skin, all the arterioles in that area dilate, blood flows to that area, and it makes you hypovolemic. So, of course, anything that, is underlying, that's just going to be accentuated with these people. So, taking a cold shower, that might be, something to manage it, but it's not going to fix anything, and that's what we see. And I'm sure you're seeing that too, that a lot of these people are just under some kind of management, but no one's actually really fixing anything.
Yes.
Would you agree?
Oh, yeah, definitely. Management is can't be what we're about. as functional neurologists. We can't be about management.
Yes.
All right, come in for a few treatments, treat it, come back in 2 months, we'll treat a little bit more, and then just on and on and on and on, this roller coaster. But I want to go back to my beginnings, which
Hmm.
was many years before your beginnings. So
You've been at this longer than I have, I know.
when we looked at a patient, when we looked at the patient, we wanted to look at the different aspects of the nerve tracks, right? So a lot of times we'd start at the receptor. Is it a
Yeah.
receptor-based issue? Is it a peripheral nerve-based issue? Is it a spinal tract-based issue, whether you have ascending or descending tracks? Or is it a reflexogenic aspect around the spine on those levels?
Hmm.
Midbrain, could it be subcortical? Could it be
Yeah.
hypothalamus pituitary? Or could it
Helps
be,
us localize where the issue is neurologically.
right, the highest
Right.
level of neurological weakness is what we were going
Right.
for, right? So we kind of like follow the nerve tracks up, and then we make an educated guess, and then how we would test the guess by doing some
Hmm.
of a therapeutic maneuver or electric diagnostic or electric therapeutic stimulation or something that stimulates it, and then we
To see
double
how it influences.
and seeing how the influence was there, right?
Yeah,
Um,
absolutely.
so But that's an important process because it does isolate the area of greatest weakness, or it can find many levels of weakness along with it.
Right.
Okay.
Right.
So when someone comes in, I've been diagnosed with POTS. I'm saying, well, what else do you got? Like, there's always something that goes with it. It's rarely simple. So
Yes.
we get body pains, we get a headache, we get temperature dysregulation, and then they have digestive issues or they have breathing problems, and so it's a many faceted issue. So it becomes that where are the weaknesses along the integration of nervous system controls? Are there many?
Right.
And how many could there be? I come up with 10 or 12 sometimes, and I'm kind of
Right.
fascinated with it. And so the stimulation becomes a complex set of stimulations to kind of get to the answer. And then as we treat them, then we focus. We get a
Hmm.
focus on where the treatment should
Like peeling the layers off an onion.
exactly. And then
You get one layer off, got a
where it
little bit of
comes
something else in there. Right.
where it comes to.
And you get more clarity. I totally agree with you. I mean, that was my experience, in practice as well. There's all these layers of stuff. But in the end, what I found, and I'm sure you're finding this too, is that if you chase all these different things, you're only going to get more lost. Because, like you were saying, I mean, we try to find the highest level of neurological dysfunction that could, at least in part, explain all the things that's happening with a person. And that would be the central area where we, focus our treatment on.
Mm-hmm.
Like you said, it could be in the cerebellum. And because of the problem in the cerebellum, they're experiencing, POTS, they have headaches, or they have an imbalance disorder on top of that. So we would kind of fine tune, and then we would look at and say, okay, well, if that's where the issue is, and that's what we're coming up with neurologically, how do we measure it?
Mm-hmm.
What kind of tests can we do to kind of assess the integrity of that area? And then once we assess the integrity, can we use those same tests to kind of guide us as to whether we're making an impact with our treatment? Because sometimes, the symptoms go away later. Sometimes you see improvement in other areas first before the main symptom shows up. So I
Yes.
kind of look at it this way. Yeah. I kind of look at the very last thing to show up is usually the last thing to go away, because it's taken all this time for the system to break down until you finally come in and say, Doc, you know what, I stand up and I pass out. But 6 years ago, they probably had something like A or B, and then, 4 years ago, they developed C, you know. So I usually find that those things tend to go away a little bit quicker than the very last thing that they come in for. Because
Mhm.
it's like the layers, you got to fix the layers as they come in and stuff like that. So, yeah, I mean,
But
I just,
you get to thermoregulation, right?
yeah.
You're really getting to an advanced system breakdown.
Oh, yeah, absolutely. It's not like a simple reflex. I mean, it's multifactorial. There's a lot of stuff involved in regulating your temperature, but it all comes down. The final common pathway, no matter where you start from, always comes down to the following. You're either going to increase or decrease sympathetic activity. That's really the bottom line. So whatever the hypothalamus is doing, whatever the brainstem is doing, ultimately it's going to work through either increasing sympathetic tone or decreasing sympathetic tone to regulate temperature, blood pressure, and heart rate.
And heart rate.
That's all you got. That's like the final. It's like a highway, right? With 10 lanes, okay, and then it funnels into 3 lanes, right? Well, if there's a backup, you can work on all the 10 lanes you want to. But until you fix the problem with the 3 lanes, you're always going to have a backup.
Yes.
I don't know if that analogy made sense, but
Yeah.
and that's the way I look at
Okay. Now,
it.
when I get some people are
Mhm.
very athletic
Yep.
and they've work out all the time, they run 20 miles a week and so forth and so
Yep.
on, and then they get COVID and now they can't work out. Now they're heat
Yep.
issues that they're having,
Mhm.
or cold issues too. They get too cold too quickly. And so once you start fixing the underlying issue, you have to get them fit again. So they have to be able to exercise. And then
Yep.
that the most important aspect of exercise is that when you're exercising, you're going to increase the temperature of your body. And so your system hydration and sweat and perspiration and having that water evaporate off the skin is the cooling effect that you get. And if that
Yep.
system isn't working right, you overheat. I've had heat stroke several times, and when I go out
Hmm.
really really hot weather, and the system breaks
It's
down.
never fun.
No, I'd run onto a lawn and I'd have I get a hose out of a house and turn it on, and it's like go like this. I come down the house like, what are you doing? We're hose. Like I'm trying to live.
Right.
I'm trying to save myself.
Right.
So with youth come very many stupid events. But
Right.
that's the most important effect. So one of the issues that I had with POTS cases and
Hmm.
and with temperature regulation is that when we start getting them to get fit again, increasing their stamina, increasing their muscle again, because they muscle atrophies pretty quickly when you can't exercise for a long time. Um,
Right.
and what we've been using is exercise with oxygen. And so we find that when we vary oxygen content with them, then we're changing the environment enough for the central nervous system and the peripheral nervous system to say, okay, we're going to work together, and
Hmm.
you can see it. When we first start, they're not working together. These people, heart rate's going all over the place. And then all of a sudden it sinks because they've run out of gas and nothing's going to work better.
Right.
And then as we change that system by exercising and changing the environmental oxygen, whether it's high altitude to high concentration oxygen, we find that we can more quickly get the patient to regulate not only their muscle system, but their circulation,
Mm-hmm.
their sweat
Totally
gland,
makes sense.
and so forth, and going
Right.
through that. And also that the autonomic neuropathy affects the temperature receptors, and it does affect the nerves that go to the sweat glands and the skin.
Mm-hmm.
Um, now, one of your
Now,
lessons
once you get to that
that,
point, though,
that hit me was that,
how so?
well, the pain receptors. Now,
Right.
when we did the last take of this, we talked about that the temperature and the pain receptors travel together, right?
Mhm.
Because when someone's in pain, you definitely increase sympathetic flow, right? And
Yes.
when you increase temperature, you increase sympathetic flow also. So it's kind of the same thing. So I'm thinking that I don't know if they can right or not, but I wonder uh, that the temperature and pain are important comorbidities, but co-regulatory aspects in the body, and that's why they travel together. And they're mostly
Right.
um, open nerve endings like C fibers, and then some of the temperature
So,
regulation can be medium myelinated fibers, but they're slow.
right.
They're slow
Like
stuff.
if right. If you're one of those people that believe in evolution, the progression of evolution, the small nerve fibers that are within our bodies, okay, were the very first ones to show up in lower animal species or lower life forms. Okay. It wasn't until later on that we developed bigger nerve fibers that had protection around them called myelin that allowed them to transmit information much more quickly. And those are kind of like our large diameter nerve fibers. So if you took somebody who have, just take a nerve in their body and cut it in half, you're going to see a combination of these big fibers and small fibers. Um, so why I mention that is that because before you had the big fibers, everything that you sensed had to be transmitted through these small fibers first. And then things got kind of parcellated out. Okay, well, now we're going to let these big nerve fibers, sense these types of things. And we'll let the small fibers continue to only sense these types of things. So things got demarcated out. So, even though we learn in school, traditionally that, your small diameter nerve fibers only pain and temperature, that's not necessarily true. They also contribute to touch sensation. They also contribute to some degree in proprioception, knowing where, body parts are positioned in space, but not as much in us as humans as in lower life forms.
Mhm.
So there's some overlap. Okay. Now, putting all that aside when it comes to heat regulation and, heart rate and all this other stuff, one thing I think it's important for people to understand is that we have a propensity to be dominant with regards to activation of our sympathetic nervous system. That is the propensity. So, and the reason that is because there's a hard reflex that occurs within the spinal cord and other areas that ensures that every time you get a stimulus from the environment, doesn't matter whether it's touch, a handshake, water splashing on your skin or something, whatever what the stimulus is, you're going to activate a nerve. That's going to transmit that information somewhere in the brain where it gets registered. Well, that activation is going to require that the nerve get oxygen, get blood supplied to it. So it's a hardwired reflex that ensures that every time you activate a nerve, you also activate the sympathetic system to provide blood flow to the nerve. Okay. So we're just hardwired inherently to have a dominancy towards our sympathetic system.
Mhm.
So what has to happen is that you just can't have the system run like crazy. So you have to have some other checks and balances. So the balances or the check marks against it are the higher areas of your brain. When as you get older, as you develop from a child to an adolescent to an adult, and you develop the front part of your brain, those areas are very significant in dampening those sympathetic responses. They keep them at bay. You
Right.
want them because you need them, but you don't want them to get out of control. And that's what you're seeing in conditions such as POTS, the orthostatic intolerances, the heat intolerances, where the system is no longer being checked or is no longer in balance
Hmm.
for whatever reason. And those are usually damage to the front part of your brain, also damage to the cerebellum. Now, you mentioned something very interesting. You mentioned, the use of oxygen. Now, what's interesting about nerves in the brain is you really only have two kinds. You have nerves that basically excite other nerves, and then you have nerves that inhibit other nerves.
Yep.
Okay? Between the two, between the ones that excite and the ones that inhibit, the weaker ones, the ones that aren't as strong, aren't as resilient, are the inhibitory ones. So when you do any type of damage to the brain, you're going to affect those inhibitory nerve fibers first. Okay. Well, guess where they reside? They reside in
I
a
had
big part
no
of the.
clue. I didn't know this at
Yes, you
all.
did.
No, I did not. I'd have to check my memory banks, but you're kicking my butt right now.
Uh,
So you're giving me a kick in the
so
brain.
I don't need to, but so where they reside, the majority of them reside in the front part of your brain,
Okay.
and the majority of them reside in the cerebellum. So when like you deprive, let's say a population of nerves made up of excitatory and inhibitory ones, and you deprive that population of oxygen, the ones that are going to suffer the worst are the inhibitory ones. They're the ones that are going to die first.
Okay.
So now you see it. Now you see a dysregulation of your sympathetic system. Heart rates go up. Blood pressures go up. You can't regulate stuff properly when you stand up. That goes haywire and all this other stuff. So, yeah, simply giving oxygen in any treatment that you do will stack the deck in for you to excite those inhibitory systems again, to get them to kick in. And then we
Okay.
have a whole bunch of other things that we can do as well, which you're already doing in your office to help those systems recalibrate. Exciting stuff, really exciting stuff. And it works.
No, it works. So I just got a patient. He's going to start next week.
Mm-hmm.
Young man, 26, been in three really tragic auto accidents.
That
And that's not the tragedy. The auto accident wasn't. The management of his case afterwards was the tragedy. So they consider him to have a mental health issue. And they're giving him a diagnosis of FND, functional neurological disorder. And the guy has been suffering for a long time, really can't go out. But the worst case of sweaty palms I ever saw. His hands are like faucets. He comes in. I said, I don't want to touch you. My hands are wet. And I said, okay, let me feel it.
That's since the accidents.
Since the accident, his hands just leak and leak and leak. And then he has to drink water because he's losing it through his hands.
Now you can't fake that.
No, you can't fake that. But I did some cerebellar uh, work with doing like
Okay.
complex movements and kind of just
Okay.
kind of pulling on his hands. And he's got this heavy, heavy tick activity where if he's just sitting there, his muscles are twitching. You can see the muscle twitch.
Okay.
And so I did some cerebellar activity, first on the left because it was worse on the left, and then a little bit on the right. Um, and it went down about 50%.
Awesome.
And he was like, okay, sign me up. I'm coming in like, I'm good. Whatever you want, how much ever, you tell me what you want. You know what I mean? This kid used to
Right.
be a pilot. He's been a pilot since he was a teenager. And he
Oh
used to do
man.
commercial flight, but he wants to get back to, being a pilot and different things like that. Um, but I knew that we were getting on tonight. And I really wanted to talk about the case because really nice kid. He does day trading. He's really good at it, but he can't leave his house very much or for a long period of time. Just like sad cases that I be getting in the office.
Well, that's sad. That's sad. And to get labeled with a disorder um, that is not consistent with what's happening with them, that's even worse.
It's even worse.
You know?
Uh,
Yeah, I mean, functional neurological, syndrome or whatever that is. That's just basically saying we as doctors can't explain what's going on with you. Therefore, it's got to be psychological. Just because I can't explain it, it has to be in your head.
yeah, it's got to be something like psychotic.
And to me, I mean, I have an issue with that because that's a very egotistical, self-centered approach to medicine. It's the doctor saying, well, I'm so great, I know everything. That's because I can't explain it. Therefore, you're nuts. It's very, very, very disheartening to see. I'm sorry. I feel bad for that because a
Yeah,
lot of these things
yeah,
are not.
we do see a lot of cases coming in with
I
maybe
sell a lot of them too.
trophic drugs, and
Yeah.
it's
You know,
it's not a good thing. Um,
getting back to our approach, obviously you found something that worked.
yeah.
Okay.
Hmm.
It made a difference, right? So like for me, when I like hear that and I hear about sweaty palms, you know, I go backwards. I try to always reverse engineer things, right? Okay, well, where's the where's the area that causes sweating to the hands? Well, the area that causes sweating to the hands is an area in your spinal cord that's located right at the base of your neck.
Yeah.
Okay, it's located right around C7 and T1. There's a little center in there. Um, I don't know if you want to know the name. Do you want to know the name? You can
Yeah.
never remember it. It's called the ciliospinal center of Budge. Some guy by the name of Dr. Budge discovered it.
All right.
Believe it or not, ciliospinal center of Budge.
I'll remember Dr. Bud.
Budge,
Yeah.
Dr. Budge. So it's the center of Dr. Budge.
Center.
So if you excite that area, you're going to increase sympathetic activity to the nerve fibers that supply your hands,
Hmm.
right? Which will cause them to sweat and all this other stuff. So when I kind of look at him, I go, okay, well, that center is not being regulated. Okay, ultimately, that area has to be excited for your hands to sweat.
Yep. Hmm.
Makes sense, neurologically speaking. You can't do it any other way. So then I kind of reverse engineer and I go, okay, well, what do I have in my toolbox that would allow me to get that area to calm down? How can I get it to calm down? You know, could I use a cerebellar approach? Just like you did. So you found that taking the cerebellar approach stimulated his system in a pattern that caused that area to calm down. So I got a little check mark. So I'm going to incorporate that. Another thing I might try some vagal nerve stimulation. Okay.
Hmm.
Not because the vagus nerve goes to that area directly, but when you stimulate the vagus nerve, let's say you're doing it in your neck, you stimulate it both ways. So it gets stimulated down, but it also gets stimulated back up into your brainstem. And then your brainstem will activate areas that will knock that area down that I was talking about.
Okay.
Okay. So that might be helpful for it. And then in combination, all right, of doing maybe both at the same time, stack the therapies together,
Hmm.
and then, I mean, you're already on track to helping him. So, the next thing to do is just to find the pattern that works for him, and then he's got to repeat it.
Yeah.
Got to do it at home and do it over and over again. Yeah, he's got to keep at it, and it may take him, whatever, 6 months, longer, for the system to re-regulate itself because he's had it for such a long time.
No, man, I think
I'm sure
I think
he's having a lot of issues
like
around.
like 12 weeks. I'm pulling for 12 weeks.
Yeah, yeah. No, you know what? I don't know because every case is unique. You know, I always like to give myself more time,
Hmm.
than what it's actually going to take. That's just the way that I, practice.
Right.
I always tell people, I always tell people it's going to take longer. So I always look better when it takes less time. Hey, you said it was, man, you did this in 3 months. You said it was going to take six, man. You're awesome. You
Yeah,
know what I mean?
exactly.
As
But
opposed to saying,
you
Doc, it's been
develop
6 months. You said it
that
was going to take
rapport with
three.
the patient,
What's
and when you
that?
develop the rapport with the patients, what I mean, you develop that connection. They get
Yeah.
better faster. What I mean, just
Yeah.
yeah,
As long as they're making progress, as long
and
as they're
make it
making
feel
progress,
easier.
they're on board.
Yeah, they're on board. Anxiety goes
You
down.
know?
They feel a little more confident that things are going to happen for them. All
Have
right.
you tried any rotational chair therapy with them?
Oh, not yet. It was just initial
Oh,
appointment.
just initial. Okay. I
Just
mean, that might be something that'd be very helpful.
start next week, and so
Yeah.
then we'll like
I
really
remember
different processes that you
Dr.
can.
Carrick seeing a case in Atlanta of a young girl who had reflex sympathetic dystrophy involving her legs. And it was terrible. I mean, it was to the point where, you know, who knows what was going to happen. They're thinking of amputating their legs because, I mean, they withered away. You couldn't touch them. It's so painful. And
I've seen a lot of
did
kids.
some rotational,
Yeah.
yes, did some rotational chair therapy with her, along with some vagus nerve stimulation. And you could almost see immediately some of the color start to come back to her legs, you know. So that might be something to consider,
Yeah.
obviously,
Oh,
you
yeah.
know.
All right. So we got about 2 minutes left. All
Oh,
right.
we do? Oh, man. Hey, you know what? Time always flies up talking with
two
you, man. We
minutes
do
of
well.
brilliance. 2 minutes of brilliance with Dr. Klotzek. That's what we'll call
All right, I'll let you make the closing statements. This is your show.
it. The reason I brought you on is that, kind of really, enhance the whole aspect of experimentation and research and looking at neurological pathways. And so I always find it interesting, because you develop your own kind of tunnel. And you got to break windows in the tunnels to see like what's outside on the other side. And the more you do that, and the reason I like having a podcast is that I really get to talk to a lot of interesting doctors that have performed greatly in their tunnel and kind of mix it up so that we're all going in the same
Right,
right. So these docs,
right.
like yourself, have developed expertise over the years that's important to share. And so, today
I appreciate that.
I'm
Thank you.
there with one of the greats. I've always thought you as one of the greats, and I really appreciate you. And hopefully, we'll
Well,
continue
I appreciate it, and
just with
working out some good stuff for you with the vertical eye movements that
yeah,
everyone's struggling with.
yep.
So
That,
I think I came up with some pretty good, interesting stuff to share with you guys. So,
all right, that's great. So I will see you in the middle of October, right?
yeah, definitely for sure. I look forward to it. It'll be fun. Okay.
Okay, I'll see you there.
And let's definitely go out and have some dinner. Not with everybody, but just kind of hang out with you, myself, and your wife, so we can chat. Okay. 'Cause
All right.
we never get a chance to do that in the big crowd. It's always just too hard to do when there's 20 people.
Exactly. All right.
Yeah.
Take
Okay.
care. All right. So
All right. Take care.
all
Take
right.
care. Bye.
Thank you for joining us on My Pots podcast. If you're looking for more support, visit us at hopebraincenter.com or follow our journey on TikTok, where we share daily insights and inspiration. Remember, healing is possible. I'm living proof. I'm Dr. Joseph Schneider, and I'll see you next time as we continue exploring paths to recovery.